welcome everybody. Good afternoon. My name is Adam Hambley, and I'm the co-chair for the ORCS Eastern Region Planning Committee. We've got a great presentation lined up for you today with some awesome speakers who'll be delivering two workshops. The first one being how to write an asthma action plan, followed by our second workshop, which is how to write a COPD action plan. But before we do that, I just wanted to send out a quick save the date reminder for our annual Better Breathing Conference. It'll be taking a slightly different format this year in light of the pandemic. And will be delivered virtually over 5 days. Each day will focus on a key area of lung health. So we have streams for asthma, COPD, lung cancer, infectious diseases, and vaping and smoking cessation. So the conference will take place Monday, January 18th through to Friday, January 22nd. And registration will open soon. So stay tuned for that. To stay on time, I think we'll roll right into our presentations. We do encourage questions and discussions, of course, so don't feel shy, but there will be an opportunity at the end of each presentation so that we'll address those questions. So you can either chime in at that point or feel free to write your questions in the chat box and we will read them out at the end. So let's jump into our first presentation delivered by Margaret Bunker, who will be walking us through how to write an asthma action plan. So Margaret is a registered respiratory therapist and certified respiratory educator and a certified medical laboratory technician. She's a graduate of Fanshawe College and St. Clair College, and she worked in hospital and home care as both an RT and a medical lab tech. Margaret has been with RG for 2 years now. And for those that don't know, RG is a best care platform for COPD and asthma management in primary care. So at this point, I think I'll hand it over to Margaret for her presentation. So Margaret, I think you're on mute. Oh, there we go.
Okay, so yeah, I'm Margaret Bunker. Good afternoon. I'm a registered respiratory therapist and a certified educator, and I'm working in primary care in clinic, helping manage asthma and COPD patients. At every appointment, we either review or create an action plan with my patients. So I'm happy to be here today to discuss asthma action plans. Our learning objectives today are how to write an asthma action plan with the current medications your patient is on, and then how to complete the yellow zone of an asthma action plan. So let's talk about some numbers. Asthma affects 2 million people in Ontario and 1 in 5 children. Asthma is the leading cause of hospital admissions for children and the leading cause of school and work absenteeism. Asthma can be fatal without proper management. However, it can be controlled. So what is asthma? Asthma is a chronic disease with no cure. It causes inflammation and muscle tightening of the airway. The airways are then narrowed and making it hard for proper airflow and difficult to breathe. With proper treatment, however, patients can live a normal life. If we look at on the left-hand side, that's a controlled asthma airway. It's nice and opened up. Air can move easily in and out. And then when we look at the right, we have an uncontrolled asthma airway. So we have bronchoconstriction, and those muscles are just tightening down on the airway, narrowing it with the swelling in the lining of the airway and some extra mucus. So that makes it quite difficult for the airflow in and out. So how do we diagnose asthma and how do we manage it? So typically the most common is through spirometry, pre and post bronchodilator. We need to have an increase in FEV1 by 12% and 200 mils in order to have a diagnosis of FEV1 post bronchodilator. So we will typically, it's recommended that you assess, you do their pre and post spirometry every time. And we use that to either assess control of the patient, maybe compared to their baseline over time, and then especially to assess response to any therapy that we may initiate or change. So the way we manage it is typically through inhalers. So bronchodilator, short-acting bronchodilator for rescue. And then we also need an ICS to treat the inflammation in the airways. So an inhaled corticosteroid. We also can manage with an inhaled corticosteroid with an added long-acting bronchodilator as well. So those are the most common. There are medications like leukotriene receptor agonist and other methods, but those are our most common. So these are CTS guidelines of assessing our asthma control, and you should be doing that at every single visit. So we look at the characteristics. We're looking at daytime, nighttime symptoms, physical activity, exacerbations, absenteeism from work or school due to asthma. We want to know how often they're using their beta agonist, and we want to know their FEV1 or their peak expiratory flow. And then we can also look at our sputum eosinophils. Now, that's not very common. You're not going to see that. Usually a respirologist is going to order that test, and I'm in London, and the closest place is Hamilton to have that done. So it's not very common. And like I said, a respirologist is usually going to be ordering that. And so they're probably going to be well managed at that point. We do, like me and my fellow educators, we do look at their CBC, and we check out their eosinophil numbers there and kind of use that to help us guide our treatment. It is an indication that there's inflammation in the body. So we do use that as well, or take it into consideration. So when my patients are in office, this is usually how I will assess it. I will ask them questions. And these are the questions we'll ask. Do you need to use your reliever inhaler more than 3 times per week? Do you have asthma symptoms more than 3 days per week? Do you have any nighttime symptoms? Have you missed any school or work because of asthma? And have you had any asthma attack or flare-ups? If you answer yes to any of these, your asthma may not be under control. So what are ways we try to help our patients control their asthma? Number 1 would be our written asthma action plan. So what is an asthma action plan? So it's a self-management tool created specific to the individual to help manage asthma symptoms and control. So we've got 3 zones here, green, yellow, and red, just like a stoplight. So green for go, yellow for caution, and red for stop. So in our green zone, we just describe the parameters for acceptable control. So these are your symptoms up here. If these are your symptoms, you're controlled. And then we want to use whatever medication that we find helps to keep you controlled. And then we'll also add our reliever for when you need it for extra symptoms. And then we have our yellow zone. So our caution or step-up therapy. This shows that the symptoms are not controlled. So if we look at these symptoms up here, and then we match them with the medication down here. So we give the patient instructions of when their symptoms are up top. We give them instructions of what they need to do. So either increase their controller medication or add a controller medication. And then we always will fill out the bottom, the reliever. So we'll fill this out later, but I'll just go through it real quick so you have an understanding. I don't know why my slides are going backwards now. Okay, so here's our red zone. This is the danger zone. So any of the symptoms up top under the description, and then you're going to follow the instructions at the bottom. So you would fill out that reliever medication to help that patient while they wait for help. So they're either going to contact their healthcare provider immediately, they're going to go to the hospital or call an ambulance, and they're going to take their reliever around the clock till they get help. So this is what they look like. You can download this at the asthma or at the lunghealth.ca. And this is what it's going to look like for your patient. So at the top there, you can fill out all that information. If your patient has a peak flow meter at the top right there, they can fill out their best peak flow. So to make it simple for the patient, it can look overwhelming with all those words. I tend to just make it simple and tell them, follow your symptoms at the top And then your instructions are at the bottom. So match them with your symptoms. So the green zone, you've got your symptoms at the top, everything's controlled, and that's your daily medication. Yellow zone, you're not controlled. This is what I want you to increase or add. And then our red zone, you have any of these symptoms, you need to take your puffer, your rescue inhaler, and you need to either call 911 or get some help. Don't wait. So then when we look at stepping up therapy in adults, I'm going to brush over the preschoolers at the top there and the children 6 to 11. We don't go into that in today's presentation, but just to give you an idea, if the child's on no maintenance, we may consider starting regular controller therapy. If they're on an ICS or an ICS LABA, they typically do not increase those inhalations, and they go right to prednisone. So 1 milligram per kilogram times 3 to 5 days. They say little kids just don't have the reserve, and so you want to get on that inflammation right away. So when we look at the adults, we have no maintenance, same thing. You're going to consider starting regular controller therapy. If they're on an ICS alone, then we're going to quadruple their ICS for 7 to 14 days. And our second choice would be prednisone 30 to 50 milligrams for at least 5 days. So below, we have the ICS LABA. The budesonide formoterol, otherwise known Symbicort, we're going to increase that to 4 puffs 2 times a day for 7 to 14 days. And then second choice would be our prednisone, again, 30, 50 milligrams for at least 5 days. Now, the Advair, Wixela, and Zenhale down here, so fluticasone, salmeterol, or mometasone formoterol, it's a little more complicated. So we're going to we're going to maximize the ICS as much as we can. There are charts that you can download, print them off and have them in your office for a quick reference. And I'll show you that in a second. But so we'll maximize the ICS, and then we will secondly do the prednisone again if needed. So these are the links. I was going to do it. I'm just worried that I won't be able to come back to my presentation. So let me I'm going to try, if you guys can bear with me and just show you, because it's, I'm just going to have to share a new screen. I'm new to all this Zoom stuff, so I hope I can just get back. So this is on the Lung Health site, and this is the table kind of describing, so your green zone on the left, and then your yellow zone recommendations on the right. So if you look, we've got ICS monotherapy all up there, and then we've got our combination therapy. So let's say, for instance, our patient is on 250 milligrams, 50 mics of Advair, or no, let's say the 250, 25 microgram, 2 puffs twice a day. Then it's simply to the right of that, you just look, it says add Flovent 250, 2 puffs BID. So that's going to be the recommendation for their yellow zone. So really you can look at anything, and I'm going to try and get back. So that's printable. You can hang that up in your office. And then you can reference that quickly. Sorry, I'm going back to my other screen. Sorry, guys. I don't know why it's not going back. That's kind of why I didn't want to do it, but.
We can see it, Margaret. Yeah, we have your case study up.
Oh, okay. So you guys can see that?
Yep, you're in presentation mode.
I don't know how it jumped. Okay, so now that we know how we can kind of look at those yellow zones, we'll try a case study and we'll fill one out together. So meet Dave. He's a 30-year-old male diagnosed with asthma as a child. His current medications are Flovent 250, 1 puff 2 times a day. And then for rescue, he's got his Ventolin, 1 to 2 puffs as needed. So his symptoms, he's waking up from a cough and shortness of breath the last couple nights. His rescue inhaler helps relieve symptoms and he's able to fall back to sleep within 10 minutes. No daytime symptoms or need for rescue inhaler except during his daily run. Dave has to take a break halfway through, which is not usual. He does not carry his rescue inhaler with him on his runs. So any questions I might have for Dave before we make any decisions? I would really, at this point, go over any other causes of his symptoms. So is he using his inhaler correctly? Is he compliant? Does he have maybe something else going on, post-nasal drip or uncontrolled allergies? So there's other things that you'd want to get thinking at this point. But for now, we'll say we've got it all under control. We know what's going on with him. And so now we want to make an action plan for him. So I'm going to get my little pointer here so I can show you. So the way we're going to fill this out is he's on Flovent. So we're going to put Flovent here in this box. We're going to put orange under color, 250 for dose, 1 puff, and then 2 times per day. And then we're going to fill in the reliever information down below. Ventolin blue, 100 mics, 1 to 2 puffs every 4 hours as needed. Then we're going to go fill out his yellow zone step up. So like I had said before, you're going to want to quadruple that ICS. So we're going to we're going to check the increase and put orange in this little box. Controller would be our Flovent to 4 puffs 2 times per day for 7 to 14 days. And then we're going to put in our Ventolin here. Also, I'm just going to add, if you have any other medication, you can put that here in the green zone. So maybe they're on Singulair or any antihistamines, maybe there are any other asthma or relevant medications you could throw into that box. So I'll go back. And then for our red zone, again, you need to seek medical help. So you look at your symptoms here. If Dave's got any of those symptoms, he's going to take, we'll write blue as in our color, and then our reliever medication, he's on Ventolin, and we'll put 2 puffs every 10 to 30 minutes as needed. And then you're going to want to instruct him, try and go over a red zone scenario and try to help him to stay calm while he waits for help or gets his help. So Dave's got his action plan now. We're going to send him home with it. And then we're going to want to bring him back for a follow-up appointment. So Dave comes back 3 months later. He's had to use his yellow zone action plan 3 times since we saw him last. He's using his rescue inhaler daily and more frequently during sleep. Dave has now stopped running and stating he gets too short of breath. So, and any suggestions there? So again, what I would do with Dave before I actually made any decisions is I'm going to have him go over his inhaler technique with me. I would like him to demonstrate it for me and make sure that he's not making any mistakes there. Also, I'm going to recommend he has an aero chamber, as he has a metered dose inhaler or a spacing device, and he can use that with that device. He can use it with his rescue and with his controller medication. It'll help more medication get to the airways. I'm going to go over exposure to his triggers. So if I've noticed Dave is having a lot of nighttime symptoms, so possibly there's something going on in his bedroom. Maybe he's got an allergy. We want to make sure the cats are off the bed or any animals are off the bed. If it's dust mites, you know, we want to go to that, wash your bedding in hot water, lots of vacuuming, getting pillow covers and whatnot. And then we really want to look at the compliance. So we don't just want to know if they're compliant. We want to know why they're not, if they are not. So is it because they forget their medication? And if that's the case, we want to figure out a plan for Dave to remember that. So I like to, with my patients, since it's an inhaled corticosteroid, I like to let him know that, if he does it with his before, when he's brushing his teeth before he goes to bed, and in the morning, that's a good time to take that. So then we're going to look at comorbidities. So does Dave have any gastroesophageal reflux disease or rhinitis? That can drip down in the airways and cause those symptoms. So now that we've ruled all that out, we're going to step up. That's what I would do in this situation, and we're going to fill that in accordingly. So I'm going to step him up to an ICS LABA. He's using his Ventolin quite often, so I think he needs a bronchodilator as well. So we're going to put our Advair here, puffer color here, purple, dose 250, 2 puffs 2 times a day, and our reliever medication there. So for his yellow zone, we have to start all over with that and change that. He's already maxed on his Advair, so we're going to add Flovent. So we're going to check off the ad, put in orange, Flovent, and we're going to do 2 puffs 2 times a day for 7 to 14 days. And that's because I've looked at that chart, and that's what the recommendations are for his yellow zone. Some physicians may, or healthcare providers, start their patients on prednisone as their yellow zone action plan. That is also acceptable. It's just really the comfort level of the provider and the needs of the patient. So then we're going to go to our red zone again, and that's just the same, and we'll fill that in. Blue, reliever, medication, Ventolin, 2 puffs every 10 to 30 minutes. So we're going to bring Dave back in 4 to 6 weeks because we've changed his medication. So we need to reassess his control and then make adjustments as needed. So before escalating therapy, I already went over this. Before you do that, you should never, without making sure you address these factors. So poor inhaler technique, poor adherence to maintenance ICS, ongoing exposure to environmental triggers. So we need to cut down on that. Comorbidities, like I spoke of, and then maybe a misdiagnosis of asthma. So in conclusion, written action plans are the foundation of guided self-management in primary care, management of asthma. Action plans significantly reduce asthma exacerbations in children when compared to care provided without an action plan. So despite all this evidence supporting these self-management action plans, delivery by physicians and usage by patients remains quite low. So if you visit the lunghealth.ca, really encourage healthcare providers to print these out, have them in their office, and fill them out with their patients, or if they have an educator, to do that in their office. And you can fill it out. There is the ability to fill it out online as well and then print it out. So there's also resources at lunghealth.ca for proper inhaler technique. You can either refer your patients to see that, or if you're rusty yourself, go take a look at. There's so many different devices, so that's helpful. And they've got all different kinds of resources available as well, lunghealth.ca, for patients and educators. And that about wraps it up.
Thank you so much, Margaret. That was great. I had a couple questions here. Some are from the chat box, and I did want to mention that Jennifer was great to share in the chat room that the link for the yellow zone, so the chart that you had up, which was great. So guys, that is available in the chat box if you want to click on that and save that link on your desktop or wherever you like to save that kind of stuff. 2 questions so far. The first one is, any idea what the minimum flow rate required to activate the Wixela inhaler?
Oh, I'm not certain of flow rate.
I know I get those questions too. They're hard to answer. Can we even give an indication of, is it one of the lower resistance devices? Is it on the higher end? Do you have any kind of experience with that?
I honestly never even had the Wixela in office. I've over the phone appointment, I've had somebody describe that device, but honestly, that's a new one to me. But if you want to know flow rates, I believe that they would be in the instructions of there should be an indication in the actual pamphlet that comes with the device. So I would assume that, but maybe I shouldn't.
Yeah, no, that's fine. Someone else had commented and just said the Wixella inhib is similar to the discus for the flow rate,
Right.
and they'll post the link for that for the group. So that's great. We have another question. The other one is, do you have a medical directive to make these med changes, or do you clear this with the physician or nurse practitioner first?
Oh, so for me, I don't make the changes myself. This is all done alongside with the physicians. So us educators go in, we go through a very thorough appointment with the patients, lots of questions. It's not as simple as what I just showed you. So it's very in depth with our program personally. But no, it's always made with the physician or a nurse practitioner, whoever the healthcare provider is. We have a discussion and we make those recommendations, and the physician either will, it's their license, not ours. So no, we don't make the changes. We just make the recommendations.
Yeah, there's a variable practice there with that. You like some people do have that directive and some don't. So that's great, Margaret. Thank you. For those that don't know, it looks like Angela has posted the Wixella information on the flow rate and a link in the chat room. So that's great. I had a question actually, Margaret, before we roll into our next talk really quickly. So you talked about step-up therapy. And I always kind of, get mixed up with this a little bit when you kind of make that determination and stepping up the ICS to say if they're on low dose ICS to moderate dose ICS versus at what point do you introduce the LABA ICS? So I noticed in your case that we looked at for David, we stepped him up to a LABA ICS. And is there a guideline where we can kind of look at that? I know I've seen them before with Gina and stuff. So do you have any kind of thoughts on that?
Personally, my recommendations are, I would try, if you can't control that patient on their maximum ICS. Obviously I could have increased that flow vent to more puffs for their maintenance. But I think it's just taking the whole picture into consideration, and the fact that it seemed like he needed bronchodilation. And so I thought he's using his Ventolin a lot more. So he may benefit and be able to go exercise again. We certainly want him running and exercising again. So it's just really looking at the benefits of so if I wanted to, everybody's different, I guess. So you can step up slowly and just go through those motions. Like I said, we could have stepped up that flow vent. But instead, based on the information I had, I felt like he would benefit from long-acting bronchodilator. So I think it's really individualized. There are guidelines, like you said, the Gina. I was going to add a slide from that that you can follow as well. So, but in my experience, I really just it's individual and
right, introducing maybe the bronchodilator sooner than maximizing the ICS dose. So it's very customized sometimes. Is that what you're saying?
Yeah.
Yeah. No, that's great. Yeah, it's hard. Like I mean, like you say, you kind of look at that whole picture and decide on where that need is. Really quickly, guys, one more question in here. It was about the yellow zone for annuity on the chart that was posted. This exceeds product monograph into the yellow zone. What are your thoughts? I do get this question often, and Margaret, you can correct me if I'm wrong. Is this typically we don't really tend to follow the monograph so much for a yellow zone? Because it's a short term, it's very kind of acute and specific, correct?
Yes, yeah, that's exactly right. So
yeah, so that's good. Yeah, there's some of them, you guys, that you will notice for that yellow zone for the inhalers, but again, it's only temporary. It's not used as like continued primary like therapy for them.
Right, and it's funny because some of them do like Brio. They say to increase, and that goes above the maximum recommendation. Right. But then they also have option 2 is prednisone. So yeah, this is what it is, the recommendations, but and in my experience as well, if we see a lot of patients that are followed by respirologists, and they'll have their patients, so Zenhale, the maximum is 2 puffs twice a day, and they'll have them on 2 puffs 4 times a day quite often. Right. And so respirology will, as you know,
they'll do their own thing.
They'll do their own thing, and then
right.
And then you'll look it up and say, oh my gosh. And
right. No, that's great, Margaret. Thank you so much. Okay, we are going to roll into our second talk here. So, Margaret, I might just get you to stop sharing for a moment.
Sorry.
No, that's okay. And we are going to roll into our second workshop on how to write a COPD action plan. This one will be delivered by Ellen Holmes. So Ellen Holmes is a registered respiratory therapist, certified respiratory educator, and a teach-trained tobacco addiction cessation specialist. She is co-running the pulmonary rehab program in the North Lanark Community Health Center. Ellen has a long history in cardiorespiratory diagnostics. She was the manager of Carling Respiratory Services Independent Health Facility, offering full PFT services at the Grace Hospital. She ran a respiratory health program and maintenance exercise program in Arnprior for the Lung Association. I just trained myself now to start saying Lung Health Foundation, and now we're saying Lung Association. Ellen also worked with the family health team in Arnprior as a respiratory educator. She is a certified cardiopulmonary technologist and an instructor for Red Cross as an advanced medical first responder. Ellen also achieved her educator certification in clinical sleep health. She has served on the College of Respiratory Therapists of Ontario Non-Council and Council, and she is a volunteer member of the Ottawa Smoking and Health Council and an auxiliary firefighter. I didn't know that, Ellen. That's awesome. Join me in welcoming Ellen.
Thank you so much, Adam. And Margaret, thank you. That was an excellent presentation. I wish I had thought of doing a case study. I don't know. I'm still a bit off my game. I just had a knee replacement 4 weeks ago today. So just trying to get my head back into work mode here. So I'm going to start sharing my screen. And everybody see that okay?
We can see that, yeah.
Thanks.
Yep.
Okay. So this is a shared presentation, compliments of Lana Barrow. She sent some slides to me to get me started because I was, a couple of weeks ago, I was still pretty much taking some heavy duty pain medication for my knee replacement. So I was really struggling with putting something together. So she sort of threw this at me and I flew with it. As far as disclosures of financial support, for this particular slide presentation, I have none. So what we're going to do today is talk about going through a COPD action plan and how to explain it to the patient. I'm not sure whether most of our attendees are RTs or already educators or nurse practitioners, physiotherapists, but I'm kind of hoping there are other folks out there that we can guide and help you with this as well. So we should be able to discuss the yellow zone to their patients because this is the change zone as it is with the asthma action plan that Margaret beautifully outlaid for us already. The participants will be able to guide and direct physicians and nurse practitioners in their practice to the current guidelines to complete the yellow zone of the COPD action plan as well. We do not have the go-ahead to make changes in an action plan without discussing it with our providers in our practice, which is easy for my colleagues that work in the CHC because they have access to the providers every day. We get together just after lunch and talk about cases and make recommendations and suggestions to the physicians and nurse practitioners at that time, or we meet with them one-on-one after the fact. And they, as do Margaret's folks, make the decision to make the changes or not, but they write up the actual yellow action plan. Not us, we just recommend and make suggestions. So as I think most people know here, COPD is an umbrella term. It is a very common, preventable, treatable disease that is characterized by persistent respiratory symptoms and airflow limitation, which is only found out on spirometry. And that's due to airway or alveolar abnormalities, usually caused by exposure to noxious particles or gases, most of the time. It can be caused by alpha-1 antitrypsin deficiency. It can be caused by other things, but the major cause is smoking related. So just a little bit on the numbers here. COPD incidence, mortality, and prevalence. This is 2014, 2015 data. And I want you to keep in mind when you look at this, that this is only capturing the people that we know have COPD. This is only capturing the ones that we've actually done spirometry with and have an absolute diagnosis. Probably about 50% of the population and beyond this do have COPD as well. And I know I see them in my community all the time. And having worked at the family health team, I saw them there, and they were often rarely referred, which is sad because we could have done a lot to help them as educators. So in 2014-15, roughly 12% of the population have diagnosed COPD, and roughly 9 out of 1,000 adults are newly diagnosed that year, and typically 1 out of 25 are dying. I'd kind of be interested to know what the statistics are now with COVID. What is of interest is that women have a higher prevalence of COPD in Canada in all age ranges. So we're making headlines, ladies. So the phenotypes of COPD are a little bit different. One is chronic bronchitis, the other is emphysema. Chronic bronchitis is basically inflammation, swelling of the airways, as well as lots and lots of mucus production. So these are the chronic cough people with lots and lots of mucus rolling around in there. Emphysema is quite different in that it is affected in the alveoli. It's not so much an airway disease per se as it is an alveolar and terminal airway disease. So the air sacs get really thin and the walls break down, and the air sacs, instead of having maybe a cluster of 20 or 30, will have 1 or 2. So the surface area for the ability of the oxygen to get into the blood and CO2 to get out of the blood and be exhaled is quite a bit less with emphysema. I love to quote Dr. Hodder's way of presenting it because it just made so much sense to me, and I use it all the time with his permission. God bless him, to my patients when I'm explaining it. He said once, if you pull all of the lungs out of a person, cut all the alveoli in half and spread them out flat, it would probably cover the area of a tennis court, okay, a flat tennis court. With emphysema, if you were to do the same, you would probably have the size of a squash court. So it sort of gives people a visual of how much movement they have of getting air in and out of their lungs. So a good way to check this at any place, and I asked my boss if we were doing this yet at the front desk, because I asked at the family health team if we could do it when I started there, is just give this lung health test to anybody over the age of 40 who is currently a smoker or is an ex-smoker. If they answer yes to 1 or more of the questions, then they really should have spirometry. It should be an automatic referral. It's just my belief. It hasn't happened yet. I'm not dead yet though, and I'm still not retired. So, and then going on to the comprehensive management of COPD, this is the newest one, the 2019 from CTS. And I really love these because it just gives it the whole picture of what we're looking for COPD. And there is, of course, one for asthma too that we saw. Looking at an early diagnosis is really critical, getting that spirometry piece in and prevention, helping people recognize that they have this, that it will progress and that they need to do something about it, and we can help them. And helping them is what we need to do. Looking at the spirometry, we do need to rule in or rule out asthma or airway reactivity. So that plus 12%, plus 200 milliliters of FEV1 when we're measuring the spirometry piece, post-bronchodilator, needs to be identified and addressed accordingly. So looking for features of asthma, he would start with a bronchodilator, anyway, a short-acting bronchodilator, either Ventolin or Atrovent. If there is asthma involved, we're looking at an ICS introduction early as well, and maybe an ICS introduction right away. So we're also going to be collecting statistics, and Margaret, I have a love-hate thing with RG. I really do love it because, and I have ever since I heard about it the first time Madonna presented it at a Better Breathing conference, is that it goes through a whole entire history and how we can, things to think about. It just pulls up things to think about all the time to make sure we're asking our patients all the pertinent questions. So it's a fantastic, fantastic tool. I would strongly promote it anytime. But it always asks these questions. It asks about CAT. It asks about the MRC, Medical Research Council information. There are two MRCs. There's one MMRC, so you can see on here, and I'm sorry I haven't figured out the pointer thing yet. I didn't get to that part of the scenario. But if you have a CAT of less than 10, then you're really not too worried about them having a lot of symptoms. A CAT of over 10 up to 40, over 10 would be a mild or mild to moderate, and then up to 40 would be severe, very, very severe disease that's affecting them. It's quality of life indicator. And the MRC's modified Medical Research Council means of measuring dyspnea or shortness of breath. The MMRC goes from 1 to 4, the MRC goes from 0 to 5, basically. So, MMRC goes from 0 to 4, and MRC goes from 1 to 5. So just basically changing where it is. And the only reason I've ever used MMRC over MRC is when I've been putting it in calculations from Bode Index. Lung function impairment, we're looking at the FEV1. Mild would be 70% or less, or and then it would be quite a bit less for moderate to severe to very severe. All through the appointment, we'd be talking about education, telling the patient what COPD is, explaining it, telling them why, explaining why the medications work the way they do. Going over smoking cessation is a really, really big one. If you can even help them cut back is better than nothing at all. Exercise, active lifestyle, getting all their vaccines, flu shot included, super flu shot is really important right now with COVID going on. And make sure they have a short-acting bronchodilator. As time goes on and they get worse, then you're looking at the long-acting therapies, LAMA, LAMA is preferred over a LABA, but physicians basically have a choice. It's just that LAMA has been proven to work a little bit better. And of course, you would include the inhaled corticosteroid if the patient is a high risk, or if they have asthma, then that's going to be included in their regime no matter what. Then looking at oral therapies like Daxis, Theophylline, Zithromax, things like that. Prednisone in a few cases, maybe. Be looking at that as things get more and more severe. Oxygen therapy, when their O2 sats drop significantly, that they require oxygen therapy. Non-invasive ventilation, absolutely. BiPAP helps get people through a lot of crisis. It gives them a chance to rest. And then they can take over breathing on their own. And the last step, of course, at the very top would be lung transplantation. And that isn't for everybody. So the reason we're talking about action plan today is because of AE-COPDs, or acute exacerbation of chronic obstructive pulmonary disease. As far as I know, this is 2008, but it's still ranking very high in hospital admissions. In 2008, it was definitely the leader of the pack. And even when you look at the 2 or more repeat hospitalizations, 1 more repeat hospitalization, you're still getting a lot of hospitalizations with COPD exacerbations. So it's basically an acute worsening for many different reasons that requires additional therapy. It requires the patient to seek help. So unfortunately, every exacerbation they have, unlike asthma, puts them maybe 2 steps backward. So they get 1 step ahead in pulmonary rehab and have an acute exacerbation requiring hospitalization, pneumonia, etc. They get worse and worse. So when they come back to the exercise program, they have got less than what they had when they left the program. So it's 2 steps forward, 1 step back, 2 steps forward, 1 step back. which makes it really tough on them, but it does give them more initiative or more motivation to not get sick or to recognize it early, which is what we're always really pressing upon them. Typically, a hospitalization is associated with a poor prognosis and, of course, an increased risk of death. In 2017, we looked at exacerbations as being mild, moderate, or severe. 2019, we're looking at two categories, low risk and high risk. It makes it a little easier to sort it out. So low risk is less than or equal to one moderate exacerbation in the last year that did not require a hospitalization or emergency visit. So this is why we have to ask them about all exacerbations. Unless they're, well, if they're having them every day, we're looking at recommending different medication for them, but we want them to look at all exacerbations when they were at home and they had trouble breathing, they had more mucus production, their oxygen was dropping, things like that. I do still keep track of that and make note of it and make suggestions accordingly. So high risk would be having greater than or equal to 2 moderate or at least 1 severe AE-COPD in the past year with a hospital admission or an emergency department admission. So case management is the big key here. COPD action plans are absolutely a vital part of case management with education. It gives the patients a tool to actually go home with and look at and say, okay, I'm in trouble. What do I have to do? I always recommend that they keep it on their fridge door. It's hit and miss, more miss than hit, unfortunately. But I'm getting a little happier that people are knowing at least where it is and which portfolio and which drawer. So I sort of subtly ask them to pull it out and have a look at it. And next time they come in, to bring it with them. And we review it again or review it online because we have it in our EMR. And then go from there. If it needs to be changed, we change it. If it doesn't need to be changed, we don't change it. If I'm thinking that I would like to make a suggestion or recommendation to a physician nurse practitioner, then I won't change it. We'll change it after the fact, after we've had the discussion, and then send it out to them by, well, I don't send it, our admin assistant sends it out. There was a nurse practitioner, I think, that did a study on COPD action plans, and he just asked me a few questions about it, and that was it. He took his whole program away and started giving people in a retirement home action plans that had COPD, but that's all he did was give them the action plan. And when we came back together, he said it really didn't work. And the reason is they need more than that. They need the support. They need to know what they're dealing with. They need to know why they're taking the medication. They need to know how to take the medication properly, et cetera, et cetera. So recommendations have been basically, I'm going to read only the last one. For patients with COPD, we suggest education with a written action plan and case management for the prevention of severe acute exacerbations for emergency or hospitalizations. And that's a grade 2B. So it's a pretty high, strong recommendation. And it does work in decreasing hospital admissions. Inhaler technique, that's another story altogether. It's not like we don't try, right? So this is the COPD action plan. Again, this is downloaded from the website. We have it in our, we're with PSS. So we have it in our EMR. So we just pull it up and fill it out. It's fillable and printable. We can give it to the patient right then and there, which is really quite amazing. But this is basically what it is. It's a little less complicated than the asthma one. But it's very, very similar in that it has a green zone. You feel well. My yellow zone is things are changing. I'm going south. Red zone is this is bad. I feel really bad. I need more help, a lot more help. So initially, I do like to write their goals because I think it gives them always something to think about. So I ask them to write their goal down, or if they would prefer, I can write it down on their behalf, but I like it to come from them as much as possible. Their support people, I ask for one. The other one is me, and I put my phone number down so they can reach me. And the other one would be a close family member, I think a family member like a husband or daughter, son. So I get them to tell me what their sputum color is. And then what makes them feel short of breath, identify that in the green zone. And they know that they need to take their puffers, and we go over inhaler technique at every visit, which is a lot harder now with COVID, unless we can do Zoom or the OTN form, or PSS, which I haven't actually done yet. We just got access to that when I went off on sick leave. But what I do is in the notes part of this is I write down their medication, and I write it down so that they understand and know what it is, or even better, get them to write it down, because then they'll remember it better. It just comes in more if they write it down themselves. So I want them to write down all of their controller medication and their Ventolin or short-acting beta-2 agonist. Oh boy, okay. Then they look at their sputum and in their changes in sputum. So I talked to them about color, texture, smell, all the different things about sputum that can change when they're getting a bacterial infection. And have they had more shortness of breath or more cough lately? I don't want them wait any more than 2 days. 2 days is the absolute maximum. If they are having more issues and they've been taking their daily puffers and their Ventolin, 2 puffs up to how many times is prescribed. So it could be up to 6 times a day if it's Q4H. So that's what I write in the yellow zone, or have them write that in the yellow zone. And if they're in oxygen therapy, they put what they can turn it up to according to the prescription by the physician. And then the red zone is when they are not getting any better, and we don't, again, want them to wait for 2 days. They're calling 911 or their practitioner, or us, but preferably someone that can actually do more for them other than us calling 911. So the thing is, with the 2 days, there are patients that get sick real fast. My mom is one of them, and it's within like 4 hours that she gets from absolutely fine, perfect, to fever, chills, O2 sats in the 80s, and it's really scary stuff. So with her, I don't wait, and we look at her symptoms leading up to it always. And we talk about that before things get worse, before things progress. And we're getting a lot better at it. But for people like that, I don't make them wait 2 days. I suggest that they get help sooner, but start taking that Ventolin every 4 hours or 4 times a day, however it's been prescribed. And they can keep taking their Ventolin if they end up in the hospital in an emergency situation. So I haven't said all that. This is the second page of that action plan. It comes in triplicate if you order it from the CTS, and which is really nice because on the back it has the guidelines for how to fill out the action plan for physician and pharmacists, and it has the back of the other one for the patient, how to actually follow through with this. So the physician, pharmacist would write in the changes that they would want this person to take if they have a bacterial infection, well, a purulent sputum, then they would start taking 1 of 2 antibiotics. If they have another AECOPD within 3 months, then they take the other one. So they alternate the antibiotics. The physician, nurse practitioner may or may not suggest that they take prednisone as well, and that would be filled in here or on a prescription. Patient can keep it at the pharmacy or keep it with them. They just have to be careful that the antibiotics and prednisone don't expire if they keep it with them. But for folks that live really far away from their pharmacy, I suggest that they keep an action pack is what I call it with them. So red zone, you're making sure that they know that what they have to do, that they have to go seek help, seek higher help, better help, more help. We also want them to touch base with their general practitioner or educator or case manager if they have one within a couple of weeks after they've had that exacerbation, A, so that we can document it, B, so that we can follow up with them and make sure that everything is okay. So reviewing the history, encouraging the patient to self-monitor, getting them to recognize those triggers or those things that put them into exacerbations is really, really, really important. And sometimes you have to work more closely with certain individuals to help them come to that place. Other people get it right away and they know what they have to do and they jump right on it. Give very clear direction of when to use an antibiotic and when to use corticosteroid. They can ask us after the prescription has been set out by the physician. We can help by all means, but we can't prescribe, obviously. And what to do if things get worse, and follow up. So this is what's on the back page of the action plan of the yellow sheet, the second page. So it just basically gives healthcare providers an idea what kinds of antibiotics work best for these certain phenotypes. So preventing an AE-COPD, optimized bronchodilator therapy is the key goal. We don't want people short of breath all the time, hopefully. Smoking cessation, vaccines, self-management with the action plan, with everything, the rehab, the exercise, everything going, dual or triple therapy, and of course getting them active, getting them moving is really, it's a hard sell, but you know what, once you get them motivated, they just don't want to do anything but. So looking at PDE4 inhibitors, so that would be your Daxis, one's for chronic bronchitis only. It doesn't work for the people with emphysema phenotype. Macrolides are the Zithromax. Theophylline is not really so much in vogue, but it is a medication that we can use. It's a really strong bronchodilator, or NAC and acetylcysteine, which patients can get at the health food store, and that just helps loosen secretions along with other things. So always look for comorbidities, look for other reasons why they could be having the attack. It could be whole kinds of things. Looking at the history of their exacerbations, what happened to them when they started getting sick. Compliance, Margaret talked about all of this, is really, really important too. And just getting the right inhaler for the right patient is so important. Stepping up, stepping down, this is in the 2019 guidelines. I'm not going to go into this because it's not really part of the action plan, but it is something that is really good to know that we can do now in that moderate or low risk, the low risk AE-COPD, as we can go up or down, titrate up or down. We just have to be really, really careful about it and make sure that we're watching everybody. Okay, and lots of resources. And I think that's it. Yes.
Thanks, Ellen. Sorry, I wasn't trying to rush you. There's so much good information here. We're just running really short on time, and I did want to give at least, a minute or so for any questions that might have popped up. But yeah, certainly lots of resources available. And honestly, we could probably do a whole other talk on step-up therapy and all that for COPD management itself too, which is great. So I did want to open it up. I don't see any current questions in the chat box, but if there are, if someone does have questions, please chime in or write it now. One quick little comment, I had a question, or more of a comment really, about action plans, was something that we run into a lot is that perhaps that resistance for providers to give that antibiotic and prednisone prescription on standby, which is a common question that does come up. And I want to share that a lot of times an action plan can still be those zones that you talked about, Ellen, right? But instead of that yellow zone, you could just put walking through the symptoms of an exacerbation, then encouraging them to contact their healthcare provider, right? And that does count as a action plan, because essentially you're walking through how to identify a flare-up. What to do is to contact your provider. So that is, and there's lots of resources on that too. I'm just going to share. If you stop sharing there for 1 second.
Oh, stop that one, okay.
Hit stop share. Oh, I think we have a question.
I think it was just to share the resources.
Oh, yes, I'm sorry. So I hope they got that already, and we can bring that up again in a second. I just wanted to give a quick little example here of something. I hope you guys can see that. So this is from the Circle of Care, the action plan, and it could be as simple as I feel different, what should I do? These are the things, and you should contact your provider when that happens. So this does count as an action plan, even though there's not a prescription for antibiotic or prednisone. So that's an alternative in case you guys get some pushback at your organizations from the providers about maybe not feeling comfortable providing those prescriptions on standby.
And there are a lot that don't. It is easier if you work in a facility that you can actually talk to the prescriber, because
sure.
most of my prescribers are out like all over the place. They come from all over the place, literally. So I write them a letter, and I include, it's a letter, and I include the yellow page with the guidelines in it, and I send that to the doctor's office and ask them to send me a copy back. But to give the original copy to the patient when they discuss it with them, because it should be their discussion, because that plan is with them. But it's not that often that I get them back. Maybe, I'm going to say probably a dozen that I've actually got back. But patients are getting them too. So it's just not 100% hit.
Right, for sure.
But them knowing what to do is the key most important thing. We can always give them the first part of the action plan, because that's always already been prescribed, and we can just go ahead and give them that.
Absolutely.
And help them better understand and recognize when to take action.
Yeah, no, that's absolutely true. I do have a question asking me to share the link for the Circle of Care. It's not a link. It was actually a PDF that I have. So I will just maybe put my email address in this chat box. So anyone that wants that PDF, I can email it to them for the Circle of Care book. So that's actually a whole booklet about COPD management. It's not just the action plans. It has really great inhaler technique, kind of instructional sheets in it. It has a whole kind of section on how to identify an exacerbation. And it's very visual, right? It's very patient focused, which is really great. So I will put my email in here so you guys can email me if anyone wants that PDF. Does anyone have any other questions?
I forgot about that. Thank you.
Yeah, no problem. We do have, we do ask the Canadian Lung Health Test questions to persons aged 40 and over, but we found a lot of false positives, so no COPD result when tested with spirometry when the Canadian Lung Health Test was administered during flu season. So we started restricting the Canadian Lung Health Test questions to smokers 40 and over only. I believe the Canadian Lung Health Test is only for people oh no, yeah, it
40.
is. Is it 40 and over and smokers, or is it just 40 and over?
Or ex-smokers.
Or
Yeah, 40.
Yeah, so
40
they do
plus.
have to have that smoking history in there, I believe, right?
Yeah.
Yeah.
They do. Yeah. Yeah.
Yeah. Thanks, Catherine.
I can
yeah,
put
that
that
was
back up if you like.
Yeah, if you want to throw that back up really quick, like type my email in here. But yeah, I'm pretty sure it's 40 and over with either active smoker or smoking history.
Oh, wait. And there it is. Okay. Oh, good grief. I still have to do this. There. Yeah, smoker or ex-smoker over the age of 40, and if you answer yes to one or more of the questions. So I have to answer one or more of the questions.
Great. Yeah. So that confirmed that. And I did send my email into the chat box, guys. So if anyone wanted those Circle of Care PDFs, you're certainly welcome to do that. And I think we're out of time, guys. We're already 5 minutes over, so I will let everybody go. I don't know if Jennifer Gloria had any kind of closing comments.
Hi, Adam.
So.
Oh,
yes.
Adam? Hi, it's Jennifer. Sorry. Yeah, I just wanted to say thank you to the speakers and to you, Adam, for hosting this session, and to both our speakers, Margaret and Ellie. Thank you so much for a great job. For those of you who don't know me, I'm with the Lung Health Foundation. Check out our website. We have more events coming up in December. So check out lunghealth.ca and go to the healthcare provider page if you want more sessions like this. Thank you both. I'll leave it at that.
Great. Thanks, Jennifer. Apparently, a lot of people are saying they can't see my email, which I don't understand. It says all panelists. I've put it in there a couple times.
Can you click choose all panelists and attendees? There's an option.
Oh, you know what, guys? That's why. Yeah. I'm sorry.
I just noticed
there we go. Yeah. There we go. Hopefully everyone has it now. Sorry, guys.
That should work.
Yeah, that should work. If someone still has trouble, don't be afraid to reach out to us. The folks at the Lung Health Foundation know how to get a hold of me.
That's right.
Awesome, guys. All right, thanks so much, everybody. Thank you, Ellen. Thank you, Margaret. Thanks everyone for attending, and we will see you again soon.
Thank you.
Thank you.